how to encourage, empower patients or people that have mental disorders, and how you can empower people on many different levels. And so that's kind of like the layout of this whole session today. I'll talk kind of briefly about little things here and there that are kind of reviews from other talks, but then also kind of fit in nicely with this empowerment model here that I'll show you in a little bit. So like culture, mistrust, active listening, things that we've already kind of talked about, touched on. And then Rick's going to finish up here in the last hour talking about the process of actually designing projects and applying them to real world challenges, which sounds really, really cool. So here we go. So this is the empowerment model I was talking about. This also is going to serve as the map of the presentation for today. So we're going to talk about how there are 5 different levels in this model, at least, and how you can empower other people based on this empowerment model. So we're going to start here in the intrapersonal section. So first off, let's consider what is interpersonal. It literally means within a person. So consider on the interpersonal level, consider what you are in relation to this empowering other people. So this section is going to be primarily focusing on your abilities and what you know and what your skills are. Because it really is, it's a selfless aspiration to want to advocate for somebody else that needs it, especially when you're not going to be benefiting directly from this. We've all gone through certain life experiences that have led us to want to be at least be interested enough in mental disorders to want to be a part of a workshop series like this. And me and Rick, of course, to actually want this to be our career. So what are those qualities that you have within yourself? Like your thoughts, your beliefs, how did they become those thoughts and beliefs? How did they influence your decision to join this workshop series? So I'm going to take a minute and ask this question. In the meantime, I'll ask you to put on your videos. It is a little bit easier for us from the presentation standpoint for us to see y'all's faces and be able to see you as we're doing our best to interact with you. So I do ask if you're, and I know we all have different circumstances. Some of us may not be decent or, we have things going on in the background. So of course, Rick and I understand, but we do ask that you go ahead and put on your cameras if you do have the ability to. So starting off, this question of these qualities within ourselves that makes us want to be an advocate. Why do you want to be an advocate? So as you have this in your mind, let me go on to the next slide here. And I put this little take care of yourself here because on the level of interpersonal empowerments, like I said, there really are certain qualities and skills to develop within ourselves for us to have the ability to be effective advocates for others. And one of those skills is self-care. This has been touched on a number of times, at least once other than this lecture, because we talked about it in the workshop number 2 that I was a part of. But self-care is just so essential. So for these next 5 minutes, I'm going to lead a mindfulness meditation session to help to bring us all into the present moment. And we'll continue on with the workshop after that. So I'll make sure this is 5 minutes and no longer, because I don't want to take up too much time. But I'll ask you all to get a seat or a position where you're comfortable, one that's alert at the same time as being comfortable. You might imagine yourself having a string on the back of your head, kind of pulling yourself upwards, not being overly rigid, but being in a position that promotes some wakefulness, especially being towards the end of the day. It can be easy to fall into this passive mode of listening rather than interacting. And so this practice here is about becoming in tune with the present moment. So now I'll have you all close your eyes and just make note of the breath. Again and again, just noticing that in-breath and the out-breath. This isn't trying to control your breathing. It's not trying to calm your body necessarily. It's just noticing non-judgmentally what's occurring. Choosing to focus our attention on the breath. Some people like to focus on the breath in their nose, noticing the cold dryness as the breath comes in and the warm, moist feeling as the breath goes out of the nose. Others feel more at home feeling the breath in the chest or in the belly. No wrong answers here. Everything is welcome. And again, this is a practice of non-judgmentally noticing what's happening in the present moment. If you notice that thoughts are creeping up in the present moment, that's okay. That's what minds do. We just think of thoughts all day long. They go in and they go out, just like the breath goes in and out. Same thing with emotions. We might feel sad or angry. We may feel bored because it's not easy all the time to focus on the breath in exercises like these. But that's okay. If you feel boredom, if you feel anything, just noticing what that feels like. What is that emotion, that body sensation, those thoughts that accompany it? Watching them as they appear and noticing if they go away. This practice develops a keen attention to those things in life which are impermanent. Noticing that no matter what we're experiencing, it's all going to pass because that's life. So as we consider, or as we breathe in and out, going back to this question of why do I want to be an advocate? Why do I want to advocate for others, especially those with mental disorders? Not trying to necessarily come up with an answer, just putting that question in your mind and looking into what pops up. And again, this is a practice of non-judgment, recognizing that what pops up when you ask yourself, why do you want to be an advocate? There's nothing right or wrong about any particular answer that pops up. It just is there. So we take a moment to notice it, come close to it. If we feel like we want to pull away, noticing that too. Now, we're reaching the end of our little 5-minute session. So you all can go ahead and slowly open up your eyes. You can take a more comfortable position if that's helpful for you. If it's also helpful, you can keep your alert position. All right. So next up, this is a very busy slide, and you all don't have to read this. You all know essentially what self-care is. These are all just things you can do for self-care. I figured it would be helpful to kind of have this, but also acknowledge the fact that any one thing on here is really dependent on yourself and the given moment that you find yourself in. There may be good times when, like, for example, this third one, you need to establish healthy sleeping habits. And it takes wisdom. It takes really close observation of what the body needs, what the mind needs in order to make that designation. a reason why self-care is so important from an advocate standpoint, I think is really illustrated by an analogy, which we're all, or at least most of us, are probably familiar with. When you go on an airplane, and we're probably not doing that much these days, but let's say it's not the non-COVID era, and we're going on an airplane. There's a sign, or there's like a series of things you go through every time you're going to take off. The flight attendant's going to say, like, all the safety things, or maybe there's a video that's going to say all the safety things. And one of them is always going to be, if there's a loss in cabin pressure, then put on oxygen for yourself. And then once you have it on for yourself, then you can put it on others. So I think that can be a helpful analogy. And it's something actually I've used when I'm finding myself really wanting to help other people, but at the same time recognizing that I really need something. And it could be something on this list. It could be, any number of other things. Just to tell you another brief story. Like I said, I'm in my first year of residency. In psychiatry, it's a 4-year residency. So Rick and I, we finished medical school, we got our medical degrees, but we have 4 years of training, which once we finish, we'll be eligible to be a board certified psychiatrist. And it's the same regardless of the medical specialty. Internal medicine is 3 years, pediatrics is 3 years. A lot of surgical specialties are 5 years. But generally these years are pretty time intensive. And especially the first year when we're kind of getting used to things, it can be a little intense. So on my medicine rotation, the question of, am I taking care of myself, popped up. The medicine rotations are typically one of the longer ones in a psychiatry rotation, like one of the more time intensive ones, I mean. We get a lot of support, but when we're the doctor, like we have to take care of everything, or find a plan for everything, document everything. And we have experienced physicians we can ask these questions about, but ultimately it's all on us. So in my second month of residency, there was one week when I was working 83 hours, just because the work had to be done. And that's not too unusual for residency programs in general. But it got to a point where it was kind of dangerous, and certainly not proud of it, but I'll say that I made some mistakes. I ordered an insulin pump on a patient that didn't need that. It's a good way to make somebody hypoglycemic if we're not careful. I forgot to order some tests that were necessary. Like, things fell through the cracks. And it took me realizing, this is not working. What can I do to improve my self-care, for me to realize, or for me to be able to recognize I am making these mistakes, not necessarily judge myself for them, but figure out what is needed for me to be my best in order to really help people. So I created a system. On my days off, I would take better care of myself, not work too hard. I would pack my lunches and get myself water every day. I set aside 15 to 30 minutes every day, regardless of how busy it was, to meditate. I would meditate in the mornings before going into the hospital in my car, oftentimes. And it was really helpful for me. That was what my body needed at the time, what my mind needed. As well as self-forgiveness for making mistakes like that, which fortunately did not lead into patient harm, but easily could have. All right, so go on to the next slide here. I thought this would be fun. I'll have you guys open up Menti and take a look. I think you'll find, so go to menti.com. You can use your phones or open up a browser. And I thought this exercise would be fun. You guys probably have experience with Menti if you've been on these workshops so far. But notice where you are on a continuum of self-care. And really, like, what you are able to do on a self-care level. Like in residency, I'd love to be able to meditate for 45 minutes, go on 6-mile run and weight training, but I can't. I could still be doing the most I could be for self-care, and so I put myself in the strongly agree category. I wouldn't, but you could. But I guess giving yourself enough forgiveness to realize your life circumstances and recognize what you can do given your life circumstances. So I see you guys are already answering. It looks like we got people kind of all over the place. Nobody's at 0. I strongly disagree, so that's good. a lot of people, it looks like, could be doing better as far as self-care goes. Some people are in the middle, and then some people are totally like on board, like a modern Buddha, just like could not be taking care of themselves any better, which is awesome. Oh, we're kind of heading towards this direction a little bit more. Awesome. Okay, keep in mind myself mindful of the time. I'm going to go ahead and move on to the next slide here, which is switching gears a little bit, still on the topic of intrapersonal advocating. I thought this would be a fun activity. Part of being a good advocate for others, and I think this falls under the category of intrapersonal advocacy, is really developing enough knowledge within yourself, or at least enough skills to be able to find the knowledge to help people. So I'm going to ask you all to go online using your phones, another window, and find the name of a mental health advocacy resource, and then post their website on here. So you can go over to a new window and copy and paste a link and the name of the website, whatever it is, and then just paste it in here once you go to Menti. So I'll give you guys a couple of minutes to do that. One example would be, oh, we got one example up here. I don't have to give you any more. So NAMI, that's a good one. We'll give you guys just a few more minutes, seconds to like look at some other ones. Nice. Okay. These can be websites that have like specific populations you might be interested in, and some people know about this. These can be, yeah, South Asian mental health, love it. These can be like different places that are specifically advocates towards one or more particular types of mental disorder, like eating disorders, depression, any number of things. I'll give you guys about 25 more seconds. Nice. Ooh, shout out to El Futuro. Love that. Here in North Carolina. Love it. Suicide prevention, SAMHSA, NAMI, blackmentalhealth.com. Yeah, there's a lot out there. Yeah, I mean, and the list just goes on and on. All right, we could probably do this on all day, all night, but I'll move on to the next slide here. Well done, you guys. I can figure out how to go to the next slide. Let's see. Oh, there we go. Oh, I went too many slides too forward. Okay, so I was just going to list on here a couple of resources I found. And again, you guys mentioned a lot of these already. Here's another slide, particularly noting that there are different populations. If you're interested in a particular type of mental disorder, you can find those organizations. So very well done, you all. Okay, so now considering culture. All right. So what is culture? Another little interactive here. I'll have you guys submit just using a few words or sentences. What is culture to you? If you can define it. Resist the urge to Google it. That's probably what my first inclination would be. Food, nice, very much a part of culture. Tradition. All right. What else we got? Awesome. And as you guys put things on here, the words that are mentioned more frequently are going to be larger in this word cloud. Nice. Wow, this is pretty cool. I haven't used the word cloud myself before. It's like dynamic. I love it. All right, give you guys like 15 more seconds. Very good. Love it. Community seems to be the top one. Values, food, customs, music, powerful. Trademarks of a people group, tradition, beliefs, system of practices, religion or religion, practices. Awesome. Awesome. All right. And again, we could probably do this all night, but I'll go ahead and move on for time's sake. I'll attempt to move on at least. There we are. Okay, so why is culture relevant? Why do I even bring this up? At least even like, why do I bring this up over the intrapersonal level? The thing is, attitudes and core beliefs vary. That is something that probably we all understand, and we all have a kind of an idea of what that means. The reason I bring this up in particular is that when we think of culture, all these things come to mind, like food and religion, and all those things you mentioned on the previous slide. And it's important to note that we can box ourselves into a corner accidentally by saying that everybody from a particular like religion or culture or any kind of group does or thinks a certain way. We can certainly notice tendencies and be on the lookout for concerns that may pop up, like people from a certain culture being disadvantaged, or maybe they tend to think a certain way, and so we should cater to this belief or to this certain way they think. But we should be very careful and note that any one person is an amalgam of many different cultures. They have their own microcultures, and so we can't certainly stereotype. We can't say, of course, if you look this way, you like this food, and we all know that. But it's important, I bring it up here to recognize a certain level of knowledge is important to know about somebody's culture. But really, humility is the most important part. And knowing a little bit about the person in front of you, setting aside any assumptions you have, letting those assumptions or those cultural things you know about a certain culture guide you to being more empathetic, but not guide you to assuming somebody thinks or is a certain way. So that's why this understanding is key here. Knowing what the person in front of you says, thinks, believes, what emotions they have is so important. And it is a reflection of their culture, but everybody is very different. And stigma is very real. So it's important to know the person that's in front of you, at least do your best to understand them. All right, so this is a slide that kind of just illustrates some of those things that I said in the earlier slide that's just kind of important for you to keep a lookout for. There are just differences in some studies that have been shown based on people's backgrounds we should be on the lookout for. So for example, this first one here, there's differences in stigmatization between Native American tribes. So like some, there's a greater mental health stigma, and others there's less. Mental illnesses are frequently seen as a source of shame in Asian cultures. So being on the lookout for that, not expecting it necessarily, but being mindful if this is something that could happen. European Americans more likely to have beliefs that mental health, essentially kind of believing that like the model that we in psychiatry learn, that mental disorders are something like related to the brain. And more so, essentially what this study was showing, more so than African Americans and Latinos. I shouldn't phrase it necessarily like that, related to the brain. It's more just this biomedical perspective, which you all probably learned a little bit about in your previous lectures. Lastly on here, there's less help-seeking behavior and more distrust of medical professionals in African Americans. And it's been shown in some studies as well. So next, thought we'd go into a breakout room, and the question being for everybody to discuss, how is mental health care viewed in your own cultural context? I'm gonna move this out of the way so I can read this. This means in your background, your culture, your amalgam of cultures, what are elements of enabling and compromising factors to mental care? So what helps mental health care? What hinders mental health care in your own culture or your own cultures, the number of different cultures that make up you and your background. So I'll have you send into breakout rooms here. If I can figure this out. Yeah, here we go. Is somebody already created breakout rooms? I see them already up here.
Yes.
Oh,
So
awesome.
everyone can start heading out.
Oh, it looks like they already are. Okay, so yeah. Go into your breakout rooms. I feel so limited to what I can see here when I'm
Yeah.
on the presenter view.
Yeah. Normally I'm just behind.
Looks like we're getting a fairly large crowd of us coming back. I know whenever I'm put in breakout rooms, I'm really chatty, so I usually end up staying until like it kicks me back automatically. But I'll go ahead and start talking. I'll give you guys a few minutes though, just to kind of put your thoughts into this little Minty thing here. So using this code here at the top of the screen, typing in just anything you guys talked about. So we already have one thing up here already. Nice. We're getting a good amount already. So young people are more open to discussing issues related to mental health freely. I did not realize that, but I could see that. Mental health in the Black community is very stigmatized. Yeah, absolutely. Lack of rural access to services. In addition to social media. Yeah. We have new forms of like like triggers for mental disorders these days than before. Very stigmatized in the South Asian community. All right. I'll give you guys like 15 more seconds and we'll move on to the next page here.
Just one
Nice.
comment I want to make, and I saw this in my breakout group as well, Jonathan. I don't know
Sure.
what to make out of it, but it's easier for people to look at like compromising factors in terms of like how culture is compromising mental health care. It's not as natural to think about enabling factors, and I know even here on this screen there are a lot of like compromising factors. And I think we have one comment that social media might be enabling, but overall it's about compromising factors, which I think is interesting.
That is interesting. Yeah. What does that mean? Are we focusing on the compromising factors, or is there so much about our cultures that makes it challenging?
Yeah, I think it's just like worth pointing out, because as a mental health advocate, you will go out in the communities and you will always be confronted with like compromising factors. But sometimes, it's probably worth like stepping back for a few minutes and say, okay, I understand like all these compromising factors, but like let's brainstorm what could be enabling factors in our culture, because not everything is bad, and there can always be solutions which are not as visible as compromising factors.
So with that in mind, are there any solutions anybody can come up with? Anything that you think is a benefit and the particular one of the cultural aspects of yourself? I'll say there's a lot of things out there. One of the things I found interesting as far as a cultural benefit, and we don't necessarily have the whys a lot of times to these questions, but we have like hypotheses and think about this. One thing is I have a lot of experience working with the Latinx population in the United States. People that are born in the United States that are Latinx, for some reason, have increased rates of mental illness, mental disorders, compared to those that were born in, say, Mexico, for example, and immigrated over here. And so, what does that mean? Is there a protective factor to being born in Mexico versus being born in the United States? It's tough to say, but we can certainly guess like what aspects of that culture are beneficial. You know, Certainly interesting things to think about. All right, I'll go ahead and move on just because we're going to run out of time. All right, so and again, because we're short on time, I'm going to kind of graze through all these things. But how culture can impact mental health is a mouthful for me. But clearly, stigma. You guys probably have a visceral understanding of what stigma is, especially if you're part of a group like this. We talked about how your culture or anybody's culture can be a source of detriment, can raise stigma. but at the same time, there are possibilities that it can build resilience. I think an easy way to think about this, or like an example, I should say, of like how culture can build resilience. This came from Rick as well, and some notes he had on this slide. But when we think about cultural pride, I like this example. There was a note here. There's a research based on like cultural pride and how it can buffer effects of racism and prejudice. And one African American in the study spoke to the centrality of cultural pride, saying, when you meet people that are doing well, when you meet people that are doing good in your cultural identity, it makes you want to do good too. It makes you want to say, well, if they can do it, I can do it. It gives you a broader outlook on the stereotypes that people have about people. This is what she said. So there's this background and her observance of other people that she sees as a member of her culture being beneficial to her. So I wanted to put a little blurb on the cultural formulation interview. This is a tool that we can use in psychiatry to find a little bit more out about the patient that's in front of us. Again, not focusing on broad stereotypes, but specific things that are important to a specific person in front of us. And it's a series of questions. It's 16 questions, and this is just a couple of examples of them. So when we're having our interview with a patient, when we're asking them about what their problems are and asking them all the psychiatry questions, we can ask them things like what's written here. And again, there's 16 of them, but without making assumptions, we can say things like, people sometimes have different ways of describing their problems to their family, friends, or others in the community. How would you describe your problem to them? Because again, our way of thinking of problems may not be the same way that another person's is. And so it's refraining from making any assumptions about this. All right, so we've moved on now. We spent most of the time talking about intrapersonal advocating. And again, we're short on time, so I'm going to be mindful of that and speed forward a little bit more. You guys already know about active listening. We talked about it in the workshop 2 that I was a part of. You probably touched on it on a number of workshops. So I don't want to belabor the point, especially since, like I said, I'm running a little bit behind. But it's just listening. It's listening, paraphrasing, reflection, all these little things here in this little active listening circle. And it's not necessarily easy. It's easy to think about it and read about it, but the practice of it is just that, it's practice, and it takes a careful self-forgiveness whenever we make mistakes, but also just paying attention to how the person reacts in front of you when you try to practice these techniques, and recognizing that it is a process of improvement, just like any skill that we all have. So moving on here. A part that I like about active listening, and we at least didn't go over this in detail in the workshop I was a part of, so I thought I'd mention it here, is making a note of people's emotions. So the emotion that somebody has in front of you. I think this is great. This is a simple diagram of different emotions, and because it really doesn't have to get more complicated than that. We can talk about other emotions, and I have this wheel here. It talks about all these different emotions, and it can be skillful to like assign like a severity to an emotion. Like somebody maybe, you know, if you look at them in their face, maybe they just look a little bit annoyed. And it can be helpful to point that out to the person that's in front of you. Like if I have a patient that is annoyed when I'm talking to them, then I'll say, oh, you look annoyed. And that can actually be really helpful. As silly as that is, like to just point out the obvious, or it may seem silly, it can be really helpful in building a therapeutic alliance, like letting the person know that like you know them well enough, or you understand them well enough to guess correctly what it is they're feeling based off their body language and the words they're saying. You know, may want to step up an annoyance to be anger if the person in front of you appears angry. And then I like, it even goes to rage here. And so I think this is very helpful to just get the severity of it. Like there was a person that, you know, was, and unfortunately in psychiatry, we see a lot of people come to the hospital a lot against their will, you know, for one reason or another. And this particular person was not annoyed, was not angry. They were furious. The furious isn't on here that I see, but it can be very helpful to point that out again. And I think that our relationship improved, you know, even though the person was here against their will and I wasn't the favorite of the persons in the world to them, but at least they felt heard, they felt understood. So this is a useful skill. It's useful. It can be challenging, like the other active listening skills, to guess it and guess correctly. If you do guess it, there's that reward of improving the relationship with the person that's in front of you. And even if you guess it wrong, then it gives them a chance to correct you. If you say you feel annoyed and they're like, no, I'm just bored. And that's fine. You now understand them better by knowing that they're bored, and you're building more skills so that in the future you'll be able to guess correctly later on. And people like Rick and I and everybody in this profession, we're constantly learning. And the patient that's in front of us, if we truly listen to them, they're the best teacher. So we just continue to practice. So I thought this would be fun if we did a little game. Name that emotion. So using Menti, I want you guys to type in this code and tell me what is the emotion you see on this person. And we'll have a few different ones. So you go ahead and just get on there and start submitting. I'll give you just like not too long, but 30 seconds or so. This one hopefully is a little bit easy. If I need to hide this in order to see y'all's responses. Oh, there we are. I have to hide, so you have to remember what the person looks like to be able to see what people are typing in. But joy, happy, that's right, that's right. The website I got this from said joy. So the gold standard, at least, you guys are quite right. I would take happy, cheerful, all of these though. So very, very good. I'll move on to the next one here. Now, name that emotion. All right, give it like 5 seconds or so, then I'll switch, or I'll turn off the camera, I mean the picture. Okay, surprised, surprise, wowed, shock, awe, emoji, I love it, love it. Very good, very good. You guys got it, you guys got it. I completely agree, and I'm, no emotion wizard or anything. At least a lot of us are on the same page. I think all these could certainly apply to the person. All right, next one. What do you see? Five more seconds. Oop, I think I pressed the wrong button. Indifference, discontent, bored, neutral. Yeah, annoyed. Yeah, this one's a little bit tougher, or it could be tough. We're getting some people that are on kind of different levels, different wheels of the emotion thing I showed you. Notice this is an African-American person. And I wonder, I challenge you all too to think like, am I having more trouble as well? Or are we different because perhaps we find it more challenging to notice the emotion, the facial expressions in people of different color? At least something to think about, whether it's true or not. All right, moving on to the next one. Here we go. All right, what do you guys see here? Oh, shoot. Here we go. Sad. I would go with sad. I think that's great. Worry, sorrow. Yeah, yeah. All right. The next one here. What do you see? Yeah, yeah, that's some anger, some raged, ready to fight. Yeah, given the context, who knows? What do you see here? Disgust, disgusted. Yeah, annoyed, irritated, agony. Yeah, we're a little bit more all over the place with this one too. All right, but disgust is the largest one. That's actually what the website said. And again, who knows where these people came from or if they're actors are really feeling this, or who knows. All right, what do we see here? This is the last one, by the way. Shock, fear, scared. Yeah, yeah, that guy looks fearful. I would agree. I would agree. And that can be very helpful to point out when somebody's feeling scared or fearful. All right. All right, thank you guys for playing that with me. Now, very briefly, I want to touch on just an important topic. As an advocate, it's important to, in an interpersonal level, not only understand the patient that's in front of you, but understand their loved ones, people that are going to be very important for the health and well-being of the patient. So general rules of thumb, offering support, emotional, physical, encouraging them to take care of themselves just as you take care of yourself. Learning, you can encourage them to learn more about the mental disorder that the person has. Just doing your best to instill hope in that person. Listening to this person just like as you would listen to the patient or the advocate that you have. All right, so that was intrapersonal and interpersonal. I'll briefly touch on institutions before we take a quick break. All right, so we already touched on this in the talk that I gave and workshop 2 about the health disparities. This is a map of Tulsa, Oklahoma, where we have this massive disparity in life expectancy. And I briefly talked about just the tragedy and atrocious, shameful history we have as having one of the worst race massacres in the history of the United States in Tulsa. And how it makes sense that regardless of whether or not somebody even knows of this race massacre, how generational mistrust of people in power can be perpetuated. And unfortunately, people with power also include doctors, and so we fall under that category of people that would be not trusted, and for good reason, because of the past that we have in Tulsa. So just recognizing on an institutional community level that there is mistrust, and what can we do when we see mistrust? I think these are some good examples of some things that you might hear or you might see people say. Doctors are just trying to make money. They just do what insurance pharmaceutical companies tell them. There are better ways to treat my condition. They had a negative outcome from listening to a doctor. The person doesn't know me. Why should I trust them? So what can we do? Really, it goes back to those good active listening skills on an interpersonal level. At a more institutional level, it takes really taking a look at the ways in which we could do better. At Duke, we've made an attempt to acknowledge this, and a lot of institutions are acknowledging their history of any number of racist activities or things they've portrayed, and making a note of that. Just saying it out loud can be very helpful. Watch your writing reflex. I like this a lot because we all have a tendency, it's a very human thing, at least, for us to want to point out what other people should be doing when really, we may very well be right, but telling people what they should. Come on, bro. Oh, little shout out from the audience there. Telling people what they should be doing differently is actually a good way to make them want to do exactly the opposite of that. So being careful and mindful of your reflex telling you to do things differently, contributing to change, and then not making assumptions. All right, so we're gonna have a quick break. In the meantime, while you guys are on break, I will challenge you to take a look at this question here. We noticed when we sent out this survey or the questionnaire between this workshop and the last workshop that a good number of people said that they do feel comfortable, and a lot of people say they don't feel comfortable reaching out to their local representative on issues that are important to them. So my question is, what would make you feel more comfortable? What does make you feel less comfortable? So these are questions you can consider during the break in these next few minutes. And we'll be switching to Rick as the speaker at that time. Rick, what is a good time to come back?
Let's just say like 8:07. 5 minutes.
All right, let's do it. 5 minutes. All right, I'll see you guys at 8:07.
All right, can you guys see my screen?
Yes, we can see it.
Perfect. Are we all back?
Should be, yeah.
All right. Well, off to part two. I think there are many different reasons why people might feel more or less comfortable talking to local representatives. I do think that, and we are now moving to the community aspect, and specifically we are looking a little bit about the aspect about how to build your environment. I think oftentimes what we see is that people know why they should act, and you kind of like realized why you should act, and that's the reason why you wanted to become a mental health advocate. You to some extent know what you should do. We give you some tools and all these kind of things, but the big question remains is like how best do we implement whatever solution is needed to target some of the challenges. And the very handy tool I want to teach you today is design thinking. I'm not going to make you become design thinkers at the end of the workshop, but I want you to understand the process, because the process itself of design thinking can have positive impacts on how communities work with each other, how you understand challenges, how you come up with like tailored solutions and these kind of things. So let's get started and look at the process of design thinking more closely. First of all, like, why do we design think? Why do we care about design thinking? Well, you might say, well, I already found a solution, and that's great. The issue is that oftentimes, like, someone's solution is impacting other people in a negative way. And so instead of just ignoring what other people say, design thinking enables us to sit together at one table and say, well, yes, your solution is great, but, and to hear from these people. And so the more people, the more stakeholders sit at the same table, the better the solution is. And the more likely it is to be adopted, because a lot of people just buy into it, not only because they're implementing it, but also because they were involved in actually coming up with this solution at the first place. The nice thing about design thinking is that there's no hierarchy. No matter if you are the CEO or the president or run a ministry, or you are like a patient or a patient relative or whatever, it doesn't matter. Every idea is equal, and everyone is equal in this design thinking process. The way it starts is to, first of all, empathize with patients or with a certain population by saying, and this is like what we call journey maps. You don't need to read this. I just like to demonstrate what I'm trying to say. You look at like journey maps for participants, in this case for patients with different types of mental illness and mental health, and say, well, before they are diagnosed with a mental illness, what did they do, right? What thoughts did they have? How did they feel? And Jonathan and you just went through like how to recognize feelings. What were they touched by? Like, what were they really like going for? What's really affecting them? And then what were some of the opportunities for improvement? And then everyone contributes to the idea of like, okay, how is the patient doing before he gets diagnosed? Then you do the same process and you look at the patient during the diagnosis, like briefly before and briefly after. And then you do the same and look after the diagnosis and say, well, how have things changed? What is he doing now instead what he didn't do before? How does he feel how he didn't feel before? How does, what are some of the touch points which he didn't have before? And what are some of the other things which need improvement? Again, the important part of design thinking is it's not a one-man show. It's not like someone is saying, okay, here's the journey map, go for it. It's really the process which is important. It's really the process of every one of you being in the same room, agreeing on the journey, coming up with like flip charts and post-it notes, and like each of you needs to be present. Once we have all these journey maps from before and during and after, and each of you can have like an individualized journey map still, but you kind of like synthesize the journey maps, you kind of like present a journey map, you synthesize this, so at the end of the day, this is a helpful exercise to just like recognize what are some of the similarities between these journey maps and what are some of the differences. And this per se is a good moment to just stop and think, okay, how come we have like similarities here? Or why do we like differ here? Why do you think he has a different perception? Why do you think this is important to improve instead of something else? So good ground for discussions. But at the end of the day, what we really get are journey maps, and we identify what some of the pain points are for the patient with a mental health condition. And based on these pain points, we now can actually start to ask what we call how might we questions. And how might we questions look for a very specific solution to the problem we identified before. The important thing about the how might we question is like each of you, again, each participant in the room can come up with their own how might we questions and with their own kind of like idea of what's going on and with their own solution. If you say, well, we identified this to be a pain point and you have like 10 people in the room, and I want to hear 10 solutions of how they think this problem can be solved. And then what happens next is like, you'll see this like little word break here, but it just means usually, you know, what happens is after everyone presented their ideas, you take a break, you reflect about these different ideas, like go through all these 10 ideas and think if they can be implemented or not. And then as a team, you kind of select the best idea. Like what is the best solution to the problem we are facing? And this is done by voting. Again, this is like the democratic process. It is not like someone in a higher position of authority has more voting power. It is really everyone is equal and everyone contributes. So you vote on the best idea. You vote on like, you know, which of the solutions you came up with will be most successful. And then you can actually start to flesh out the solution and like make it happen by prototyping it. You can design it, you can literally draw it, you can think about services, like who needs to be involved, what is the flow diagram. If you think about the product, you can like also just draw it. And that's one way of doing it. And the important part of design thinking is it is an iterative process. Just because, you know, you're doing it once, you come to a solution, you come to a prototype, it doesn't mean this prototype will be successful. What you then do is like you're testing it, you get feedback, and then you start again. You reiterate it, you test it, you get feedback, but most importantly, eventually it will be implemented. Now, this is a very short and brief introduction to design thinking. I just want you to understand the key components and really take away that design thinking can be very effective for the reasons I mentioned. But again, I emphasize it again, it's mostly because design thinking is done on a non-hierarchical level and each of you contributes. And you will see this when you will go into the breakout rooms in just a few seconds. Now, let's remember one thing. When we think about mental health solutions, then mental health conditions are way more than medications. So mental health, I guess, care solutions are way more than medications. On one hand, we should never forget that mental health is really like a biopsychosocial model of care. There are biomedical factors. We know these ones can be targeted with medications, but we have behavioral factors which might respond to psychotherapy. We have the political environment, the legal environment. We have social and cultural factors, as Jonathan was talking about before. So really, when we think about solutions for patients with mental health condition, we not only need to think about how can I get this patient to treatment, but there are many more things how we can support a patient with a mental health condition. The other principle in mental health to think about is the idea of equity versus equality. And so each patient really, it's not like the idea as seen here on the left side, it's not the idea we treat everyone the same in the mental health field. As Jonathan was just pointing out, there is mistrust from certain populations. There is stigma. Culture plays a big component. Emotions play a big component. And so really what we need to do is like equity. We need to meet our patients where they are and come up with solutions that are tailored to the patient needs, instead of just saying, well, this is what we have done in the past. This worked perfectly well for a certain population. It might have, but it might not be appropriate for the patients we are seeing in front of us and the patients you will see as a mental health advocate. Now, for our first breakout room, I want you to look at this particular question. And I'm going to read it to you, and you can also just follow it. But this is the one thing I want you to think about as a group, each of you. How might we, and this is as a team, improve patient diagnostics and therapies in a world where the people around the patient don't want to use scientific methods, or in a world where the people around the patient want to resort to spiritual evaluations? And I think this question is actually pretty important, you know, after I joined some of the breakout rooms earlier tonight, where we are talking about, what do you do with patients who end up like at the religious institutions? What do you do with patients who are not agreeable like to any scientific solution or idea or treatment? So this is your question for tonight. I want you to brainstorm about. The way we are going to do it is that we will have, let me just actually go back one more slide. Okay, this is not showing up. Let me just go out here for 1 second. All right, so this is not showing up on here. So let me just like actually open the PowerPoint. I want to give you like one or two solutions, what has been done elsewhere, to give you like a rough idea of what we are trying to do. Just give me 1 second as I open the PowerPoint. Can you guys still see the slides?
Yes.
Okay, perfect. So one way of acknowledging that not everyone, not every patient, not every relative wants to use scientific methods and go to the hospital is, okay, if someone doesn't want to go to the hospital, this particular person, why shouldn't the person be treated at the church? And we can offer community-based care. And this is also like, referring to the second part of the question, which is like, okay, if people want to resort to spiritual evaluations, why shouldn't we just do the diagnosing and the treatment in the spiritual community instead of like bringing them to the hospital? And this kind of idea goes back to a design thinking workshop I moderated in Ghana, where I worked with the government and communities. And the question for us was exactly the same. What do we do with patients who don't want to go to the hospital, but who we still want to see from a mental health perspective, to diagnose them and to treat them? And so we came up with the idea of the brain spirit desk. And the brain spirit desk is the idea that there's facility-based healthcare, and facility-based healthcare is important. But most importantly, the majority of healthcare can take place at communities. And this is either by having mental health nurses, going to churches. This can be by training spiritual leaders in mental health care, so they can do some quick screening. They can do offer some basic psychotherapy with supervision. This can be they identify people who would benefit from facility-based mental health care, hospital mental health care, and they can transfer patients. And then it's also like about awareness creation, like having them talk from their perspective about how spirituality affects mental health, but also have them talk about how spirituality and neuroscience are interconnected. Also have them talk about how we can destigmatize mental illness. And out of the sudden, it's not like a black or white decision where we have to say, well, do you want to get like medical treatment at a hospital, or would you be okay with like spiritual treatment? It's not like either or. It's really like, how can we combine medical treatment in a good and efficient way with religious and spiritual treatment? And so the Brain Spirit Desk is actually aiming to increase the treatment in Ghana, or like at a particular Ghanaian institution and community, from 10% what is right now at the facility-based care level to 30% over the next 5 years. And again, we are doing this by actually working with spiritual leaders. And that's one way of offering mental health care to those who don't believe in science or who don't believe in the idea of spirituality. So that all being said, here's your task. I want you to go into breakout rooms and tackle this question. I'm actually going to post the question in your groups and as an announcement. So, but if you want to take a screenshot right now, if you just want to jot it down, that's great. And what I want you to do in your small groups, you're going to brainstorm. Again, what we are doing is we're trying to find a solution to this particular question, which we have identified. It's an issue. You might identify this as a mental health advocate, and I want you to think about what are some of the solutions to this particular question. Don't forget that each of you needs to come up with one solution. So if you are a group of 7 or 8 people in your breakout room, you guys need to have like 7 or 8 solutions at the end of your breakout session. You can discuss them, like just mention them, and then you can discuss them. Or if you don't want to discuss them, you can also just put them in the chat and just like, brainstorm about this and like let other people know what you think the solution is. Then one of you is actually documenting all these ideas. Again, this can be done in the chat. This can be done in a Google document. This can be done on a Microsoft Word document, whatever you guys prefer. But just, it's important to write down all the ideas from all participants from your group. And then as a team, like in the last minute or so, you actually as a team decide out of the solutions we have gathered, which one of these solutions is the best solution to solve the issue we have identified up here. And so then you will actually report this one solution after you came down from 7 or 8 solutions, which you had initially. You will come down to one, and you're going to post this idea to Menti. And then as a whole group, we are going to look at all the solutions. Again, if we are like 80 participants tonight, we might have 80 solutions initially. But then in your breakout rooms, each breakout room comes out with one particular solution, which you then post to Menti. And you have about 10 minutes for the whole exercise. Do you guys have any questions about the exercise before we go into breakout rooms? If not, then I think now is a good time to go into breakout rooms. All right, can you see the code? Perfect. Let's see like how many ideas we can come up with.
Maybe, are you able to zoom in or press the presentation? It's a little bit small on my screen, the code.
Yep. Is it better?
That is better.
Perfect. Do you already see any posts on your end, Jonathan?
Not yet.
Okay.
We definitely talked about a solution in our group, so there should be
one.
at least one.
All right, while we're waiting for groups to potentially submit some of their findings, do you want to tell us briefly about what you guys discussed?
Sure, might as well. So we had a few ideas that were thrown in there. One that a group member, and this wasn't my idea, one that a group member had mentioned is perhaps making a workshop about spirituality for providers and community health workers, specifically aimed for these particular providers and community health workers that work with people who may not believe in the scientific method. So it's more of an educational kind of program.
Yeah.
Yeah.
Love it. Why don't we, like, while we wait, why don't we like take 1 or 2 more minutes to submit? Let's see if there are any submissions, but like we can also hear from people. Just unmute yourself, or as someone is saying, I definitely submitted something that isn't showing up. Maybe it needs to be refreshed. Okay. Oh, same here. Okay. Let me refresh.
Yeah, I just submitted something too, just to see if it'd work. People are like, I did my homework, I promise.
Maybe you should share your screen. Oh, here we go. Oh, 12 solutions.
So.
That's great. I'm
Look at
sorry.
that.
Here we go.
See 2 of the same solution, because I put in our group solution.
All right, so we have community partnership for trust building. It's great, love it. Incorporate mental health training as part of standard training. Yep, perfect. Have some sort of public campaign to educate people about the biological factors, encourage them to both seek. Yeah, That's like one of the biggest challenges. Oftentimes when I talk about mental health from a medical perspective, people start saying, oh, do you tell me not to go to my priest anymore? And I said, no, it's not black or white. You can pray, you can seek your support from your friends and family members, priests, congregational members, but you can also take medications. So you're absolutely right. It's not black or white. Workshop, yep, where they learn about scientific methods, even better, because if people learn about scientific methods, they can also publish eventually, right? And like the more like gathering data, publish, and make other people aware of what they are doing. Training members, mental health advocates, yeah. Yeah, I think you're absolutely on spot. Like it's bi-directional. It's not only one way, where we teach like spiritual leaders about mental health, but also mental health leaders about spirituality and religion and how this intersects. Yeah, that's great. So it seems like there's a lot of like you guys agree on like how best to solve this, which is great. And I think you know, giving the population you guys are going to serve, this might actually come up. And so the kind of like exercise we took was not just a random exercise, but you know, it might be helpful for you to go forward and like think about some of these things. In fact, you know, even in the US, like I told you about my work in Ghana, but even in the US, there are a lot of like places where spiritual and congregational communities are taught in mental health and mental health professionals and spirituality. One of the examples is in Baltimore, with Dr. Hale, something to look into, but something which can be easily reproduced down here in North Carolina as well. Now, let me actually, given that you guys all like had the same and similar idea, let me actually go and skip one slide. We don't need to come up with what is the best solution out of like the best solutions already, because you guys had similar ideas. But let's rather look at like, you know, the next level. Now that we come up with something very tangible, we know like we need to involve communities. We know we need to do teaching, awareness creation, workshops, sensitization, destigmatization, these kind of things. Now the question is, you know, to what extent do we actually need policy to be involved? And this is the last level of empowerment we are going to talk about. And you know, some of it is just like we don't need policies to make workshops happening, right? But on a bigger level, eventually you can think about what actually needs to happen to empower spiritual leaders to provide mental health care. What needs to happen for mental health professionals to also, you know, transfer to spiritual communities and these kind of questions. And this brings us to the big like topic of policies. And I think, you know, I briefly wanted to take this opportunity to talk about what constitutes a good policy. Why do we do policies at the first place? And you will see that a lot of the ideas, which I'm going to talk about right now, they're actually coming from also from the design thinking field and vice versa. So policies at the first place is just like saying, well, we have identified there is an issue, right? If there's like a housing policy, it might be because there has been some issue identified with housing and there's a public discourse, which is always good. If people talk about it, something happens. The good thing is that with policies, it's not like, in most cases at least, it's not like subjective. I'm not just saying, well, yeah, I don't want you to have like more than 2 houses. But it's really like based on like assumptions at the first place, beliefs and attitudes, which are then validated through research and supported by evidence. And so this makes like policies, sets goals, sets objectives. I can say, well, the government failed us, right? The government tried to do X, Y, Z, but it really didn't do this. Like, you know, money spent on mental health care, percentage of patients which have access to mental health services, treatment improvement, treatment gap, like the gap between patients who need treatment who don't get treatment. Policies really helps us with like, you know, thinking about these kind of things and putting some numbers onto it. Policies can also be about trust building, because out of the sudden, you know, people need to start working together, different departments, different stakeholders, different actors. And I'm going to show this in just a bit, but it can also be just the process of policymaking can be a trust building exercise. Now, when a policy is usually drafted, well, either a large population is affected, and with mental health conditions, we can fairly say, yes, a large proportion of the population is actually affected. up to 25 to 30% of the population at some point in their life is affected by a mental health condition. The other thing is like if the consequences of being affected are severe, and so yes and no, right? I mean, what is the perception of severity and like for what population? But then the next one is good news. Policies are oftentimes drafted if advocacy efforts put pressure on decision makers, and this is you guys. You know, you have this unique position as a mental health advocate to listen to patients, to listen to providers, to listen to relatives, and then work with them through design thinking or through whatever, you know, mode you choose to then like push forward and actually advocate for policies which are needed. Policies around mental health and homelessness, policies around like deinstitutionalization of mental health care. We need more mental health hospitals, policy for funding of like mental health care. And not saying you're the only one trying to solve it, but the more voices are out there, the more voices are heard, the more likely the whole problem gets solved. And again, some insight about what constitutes a good policy. I've put some of the things here on this slide. And I want to highlight something which I already highlighted last week. Oftentimes in mental health care, we talk about those who are affected. But really what matters most in mental health care is nothing about us without us. And it's really about hearing from affected patients and, you know, taking the opportunity to have their voice heard in the process. Again, there are different actors. You're only like part of like the whole system. I understand there are many more actors in the system, but you see how important you are, like, and how many different levels you can actually influence policies. The good thing about policies is it's not a linear model of a policy process, which is seen here, which you used to think it is, where it's like, okay, there is an issue, we design a policy, and once the policy is fixed, it's fixed, we implement it, we look at the outcome, and that's it. Really, what policies are really about is it's a more iterative approach. You plan, you do, you study, you look at like, does the policy do what it was supposed to do? Does it do something else? Does it have unintended consequences? And then we change something, and then we start again. And so this is, again, a good step for you to step in and to actually empower patients, empower relatives to also speak up and to make themselves heard in the policy process. I want to briefly talk about unintended consequences. That's like one of my pet peeves. But I think, like, as I said before, oftentimes we come up with solutions, but then we forget that, you know, every solution we come up with, almost every solution has like negative consequences. Some of them are well foreseen and we can think about them. And it's like, well, yeah, of course, if I like cut funding for mental health care, I will potentially see more people with a mental health condition, people who cannot work, who might need unemployment checks, who might actually need apartments and these kind of things. But if I cut mental health care, I might also see a higher number of people being imprisoned. And then I also need to ramp up the prison system and think about, you know, how best can I restructure the prison system? Because people might end up in prison. Is this a right thing or bad thing? Well, we talked about this last week, but, you know, oftentimes policies have unintended consequences. And I want to give you like another example of an unintended consequence. This example is just like nothing to do with mental health, but I think it's very good to just like understand unintended consequences. So let's say our activity is providing a monthly stipend to mothers. We kind of like, we have identified a community which, you know, has low income. And we are saying, well, yes, we can give you some money to the mothers if your kids go to school. So we're not only supporting the family financially, but we are also incentivizing for people to get education and go to school. And the outcome is, if someone goes to school, then the kid will, you know, have an easier chance to get a job and get income. And then if you pay families and give them some stipend, they will actually not be in poverty, but they come out of poverty. And so you can break this poverty social mobility cycle over generations. The issue is that now you might say, well, you might pay the mothers, but actually now the husband or the father is taking less responsibility. And at the end of the day, the household income doesn't increase at all and the family still stays in poverty. Or you can say, well, maybe another outcome is that, you know, with the extra money which you now have, people start to change their food patterns. They now eat more junk food because they can afford it. And then you can say, well, if you eat a lot of junk food, actually there are negative mental health and health consequences, like such an increased cardiovascular disease, And then you can say, well, but this costs more money. And eventually the family needs to spend money on healthcare instead of using the money to get out of poverty. And then what you see is like, instead of like, making kids healthy and having them a job, you make them unhealthy. And instead of like having families coming out of poverty, you actually create unhealthy communities. And this is really the point of unintended consequences. So it's always good to think about this, even in your advocacy work, even in your empowerment work. You think about, well, yes, you're requesting one thing, but by doing so, what might be some of the unintended consequences? Once you've figured out all of this, I think, there's the House of Representatives, and I just like, posted the homepage on here to show you how to find your representative. There's the Senate, and I know these people get a lot of emails and mails and whatnot, but again, it only takes like a handful, a number of people, and again, a number of people, and again, some people who write about the same issues, and there are chances that things might improve. But again, we don't need to think about the policy level necessarily to empower. We can start small in our own communities, and we can see how we can actually make the situation better. For example, by using some of the design thinking methods I talked about before. And I think with that, I just want to switch back to the main PowerPoint, but also just stop here and give you guys the opportunity to ask any questions you might have about whatever we talked about tonight, or in general. The stage is yours.
Hi, I just wanted to say one thing about political advocacy and, calling on our representatives to do what they're supposed to do. Being able to vote for a representative is just part of our duties as citizens to do stuff, but the real work and the real change actually comes from individuals and communities mobilizing and actually coming together to change things. So, that being said, it's always important to reach out to our politicians, our representatives, but also important to take action.
Yeah. And oftentimes you should not forget, politicians are looking for community projects. They are looking for ways to get reelected. And we can use this to advocate.
We could also use these last few moments just to, let people ask questions or speak about what they thought about the course so far. And then we can begin sort of like winding down at 8:55. Cool. Well, it looks like we might have a couple of minutes. If there are no questions, then I guess we can start sort of talking about what the next steps are.
Yeah, that's okay. So the certificates of completion will be sent by the end of March. We're going to start working on that, just confirming the attendances and that you all completed what you needed to do. So expect those soon. And you probably just received an email not too long ago about focus group sessions that are happening this week. So this is going to be a session where some of us are just going to debrief on what you thought about the program and, just give us feedback about it. These are totally voluntary, so you don't need to attend, and there'll be two. So you can either attend the one on Wednesday from 7:30 to 8:30, or the one on Thursday from 7:30 to 8:30. You don't have to attend both because they're going to be the same thing. So soon you'll get more information about becoming a volunteer, and that'll be sent through email within these next few weeks. We're still working out some of the details, so we'll put everything on that email. And just an FYI, there's going to be a general application on, basic questions like, why do you want to be an advocate? And your general information. And then from those applications, we'll go on to an interview process just so we can make sure we confirm. Are people saying things in the chat? I don't know. Oh, okay. Well, thank you, Bruni, for sending that.
Group interviews.
Yeah, they're just going to be group interviews, pretty like casual. We just want to make sure everyone can converse and just get some practice before becoming an actual volunteer. And lastly, we are going to have summer internship positions to join the LMHA 2021 to 2022 team. So pretty much the team right now is a few of the students who you've seen working. You know, there's a lot of work going on behind the scenes, and we do need some help if we want to keep this program going and have another set of workshops in the future. So there are going to be different positions available, and more details on that will be sent. But if you've enjoyed the program and you want to, you know, have a leadership position or just want to give back and have the time to give back, this would be really nice, because we could definitely use some help. And that's all from me. But if Bruni, do you want to say anything?
Yes. So after this meeting, you will be sent out your last anonymous short, feedback survey, as well as a form in which you guys can upload a screenshot of your caring with compassion modules. There were a couple modules complete on that, and yeah, as Ayana said, you should be getting your certificates soon. And also reach out if you have any questions. Thank you guys again for just being so engaged throughout these past 6 weeks. And we're really looking forward with working with like future volunteers, and also just excited for the work we will be doing with our mental health organizations.
Yes, so thank you. And also quick shout out to Jonathan and Rick. You all were just two of our amazing presenters, but really this program would not have been possible without you. Okay. Really, thank you so much.
Yes. Oh, one more thing. If you only miss one session, yes, you'll still get your certificate, and all of the PowerPoints are on our website. The videos have also been uploaded to our website. Those videos are currently public, but we will take off those videos online on May 1st. And just so you guys know, I know I've reiterated this, but our volunteers through the program, time commitments and more information will be sent in the email about it. But we are hoping to have our volunteers do refresher courses maybe once every 3 months or something along the way. So there'll be continued education for those who want it. Yep, that is it for me. Any last questions before we end for the night?
I'm just saying, like, you can pay us back with taking good care of patients we discharge as mental health advocates. And then hopefully when they need to be admitted again, or we see them in our outpatients clinic, they will tell me person XY who participated at the workshop actually made me come here. This would be the best outcome we can envision.
Yes. All right. Well,
sorry, I have a question.
Go for it.
I missed some of the work, and I emailed the
LMHA.
LMHA.
Yeah.
Yeah, and I completed most of it.
Okay.
So like 90%, like it's like on the website. I made an account, I logged in, and so I just want to make sure, like, is there anything else that I needed to be completed?
No, that's it. Just the assignments. You've been coming to the lectures, and just when we send out the form, just like send your screenshots of the caring with compassion modules.
Oh, okay. That's what I wanted to know. So we wait for them to send it out.
Yes, and you'll just
okay
the Google form.
In our Google form. Okay.
Right.
All right. Well, it's been exciting. Thank you so very much. I appreciate you all. I don't even know. Is everybody from North Carolina? He said when he gives out his patients, when you want advocates to be there to follow up.
Or you just send them to Duke.
Oh,
from all the US.
That's a long way.
I know.
We just have a new mental health facility opening up this April.
Yeah, and there is telehealth these days. So.
That's right.
Oh yeah, telehealth. Yeah, it makes me want to come there for my chaplaincy CEPs.
There you go.
Yeah. All right. Well, it's been awesome.
Good night, everyone.
All right, good night. Blessings.
Thank you, guys.
Thank you so much.
Thank you.
Night.